acid-base balance. This video is on acidosis. Now, in metabolic acidosis, the basic change is deficiency of bicarbonate, can also be due to increased production of acids or reduced excretion of acids. In all these situations, there is increased concentration of hydrogen ion, as a result of which the pH decreases and acidosis sets in. What happens to this ABG analysis? The pH is decreased, bicarbonate is decreased, whereas partial pressure of carbon dioxide is normal. Now, one more concept we need to understand with respect to metabolic acidosis is anion gap. Now, what is this anion gap? Inside our body, the concentration of cations is not equal to concentration of anions. There are many unmeasured anions which include sulfate, phosphate and proteins. So this represents the anion gap. And how is this anion gap calculated? It is a difference between sum of concentration of cations minus sum of concentration of anions. So the normally sodium is the major extracellular cation and the average sodium concentration is around 140 millimoles per liter. Potassium average concentration is 5 millimoles per liter. So bicarbonate concentration is around 25 millimoles per liter and the average chloride concentration is around 105 millimoles per liter. When we substitute all these values in this formula, so this anion gap is around 10 to 15 millimoles per liter. Now, so this anion gap can be increased or it can be normal in metabolic acidosis. So when the anion gap is increased, it is known as high anion gap metabolic acidosis. In some situations, the anion gap is normal, but the concentration of bicarbonate is very much reduced. As a compensatory mechanism, there is increased in chloride concentration. This is also known as hyperchloremic metabolic acidosis or normal anion gap metabolic acidosis. Now let's understand what are the different causes for high anion gap metabolic acidosis. Now, so the first important cause is diabetic ketoacidosis. Here it is characterized by chronic hyperglycemia because of relative deficiency of insulin. And as we all know, insulin is an anabolic hormone. When there is deficiency of insulin, there is increased catabolism of fatty acids by beta oxidation, resulting in increased formation of acetyl-CoA, and this gets diverted to form ketone bodies, and these ketone bodies, especially the acetoacetic acid and beta hydroxybutyric acid, accumulates and result in development of high anion gap metabolic acidosis. The next condition is renal failure, where there is impaired excretion of H plus ions. So this results in accumulation of acids and contributing to the development of high anion gap metabolic acidosis. The next condition is severe exercise, where the cells shift to anaerobic glycolysis with increased production of lactic acid, contributing to the development of high anion gap metabolic acidosis. Chronic alcoholics, what happens is the alcohol gets oxidized to acetaldehyde with generation of large amount of NADH, which reduces pyruvate to lactic acid, resulting in lactic acidosis and subsequent development of high anion metabolic acidosis. Coming to causes for normal anion gap metabolic acidosis, where the anion gap is normal but there is loss of bicarbonate, as a compensatory mechanism chloride gets increased. This is also known as hyperchloremic acidosis or normal anion gap metabolic acidosis. The causes include severe diarrhea, where there is loss of bicarbonate in the intestinal secretions, resulting in a development of normal anion gap metabolic acidosis. The next condition is renal tubular acidosis, where there occurs defective reabsorption of bicarbonate at the level of PCT, resulting in the development of normal anion gap metabolic acidosis. Next is a drugs like acetozolamide, where which is nothing but carbonic anhydrase inhibitor. So there is no generation of bicarbonate. So normally what happens, carbon dioxide produced as a result of metabolic process in the renal tubular cell condense with water to form bicarbonic acid, which dissociate to form H plus ion and bicarbonate ion, and this gets reabsorbed. So carbonic anhydrase inhibitor, so what happens, inhibit this enzyme carbonic anhydrase, so there is no generation of bicarbonate, resulting in development of normal anion gap metabolic acidosis. So the next condition is ureterosigmoidostomy. It is a procedure where urine, both the ureters are implanted into sigmoid colon, and the urine is diverted to sigmoid colon with loss of bicarbonate, and same condition, loss of bicarbonate is also seen in intestinal fistula. So in all these conditions there occurs normal anion gap metabolic acidosis. So how to investigate a case of metabolic acidosis? Now let's consider the ABG parameters, the three important parameters. pH is decreased, bicarbonate is decreased, and partial pressure of carbon dioxide is normal. Now just check the electrolytes, potassium chloride and calcium, all these are altered in metabolic acidosis. Now there occurs hyperkalemia in metabolic acidosis. The reason is when there is increased concentration of hydrogen ion in the circulation, it is taken up by the cell. In order to maintain the electrochemical gradient, potassium is pushed out into the bloodstream, resulting in hyperkalemia. So the next is hypercalcemia. Why there is hypercalcemia? It's known that albumin is a binding protein for all most of the cations and anions. So in whenever there is increased concentration of hydrogen ion, it goes and binds to albumin, displacing the calcium from its binding site, thereby increasing the blood calcium, resulting in hypercalcemia. Now, how is this metabolic acidosis compensation? There are two important compensation rules. A compensation always involves the counter variable and in the same direction of the primary variable. Now, let's consider this Henderson-Hasselbalch equation, which states that pH is equal to pK plus log of bicarbonate to carbonic acid. In metabolic acidosis, pH is decreased, bicarbonate is decreased, whereas partial pressure of carbon dioxide represented as carbonic acid is normal. So how is this now compensated? The primary variable here is bicarbonate and the secondary variable is carbonic acid. Primary variable is decreased, so compensation occurs by decreasing this carbonic acid. So when metabolic acidosis sets in, all the three different mechanisms of regulation of pH come into picture. First one are the different blood buffers. They will not go for completion because they are capable of just resisting the change in pH to a minimal extent. So the second line of defense is by the lungs. If the lungs are functioning properly, so what happens? Fall in pH stimulates the chemoreceptors, resulting in hyperventilation and decrease in carbonic acid. Now this respiratory regulation responds within few minutes but do not go for completion. So the final regulation is mainly done by kidneys. And as we all know, there are four different mechanisms by which kidneys excrete the acid. First one is excretion of H plus ion, then excretion of titrable acid and excretion of ammonium ion. On the contrary, bicarbonate are reabsorbed. So all these four mechanisms will come into picture and restore the and compensate this metabolic acidosis. So this was all about metabolic acidosis. Next video will be on metabolic alkalosis. Please do like, share and subscribe this video. Thank you.